What we're doing here is we're talking about basal skin cancer. Basal skin cancer is the most common skin cancer in the world. It accounts for about 80% of all non-melanoma skin cancers. About 3.6 million people worldwide per year have this type of skin cancer. It doesn't only affect white people, it can also affect blacks. And the most common location is the area that you get the sun, most amount of sun. Although you can get it in the armpits and areas that never saw the sun. I had patients who had it on their genitals, in their armpits. And there are some conditions with mutations that can have them looking like moles. They actually look brown like a mole. It's called basal cell nevus syndrome. So it's nothing that one needs to worry about, but the key is to make sure that you detect it early. To detect it early, you need to see a professional, preferably board certified dermatologist once a year at least, to make sure that if there is anything that looks like a pimple, doesn't go away in a month or two. If you're not sure, better take it for a biopsy. But basal cells can appear in different ways. They can appear as a pimple, they can appear as even a scar that doesn't heal. You know, you thought like, oh, maybe I hit myself. I had many situations where patients came in, they said, oh, I was swimming in the ocean, I hit my head and then it happened. Doesn't matter. You do not listen to that history. You listen to it, but you have to follow your gut instinct. And if your gut instinct tells you something suspicious about it, and the issue is they grow very, very slowly. Those are called morphiiform because they look like a scar, from morphia, standing for scar. And then there is pigmented basal cell, etc., etc. So there's different variety of basal. So what you can see here is one of the forms of basal cell, and this is the morphiiform basal cell actually combined with a nodule, a typical basal cell. And if you look very, very closely, you'll see that here this area looks like a scar. And this is a big area. This goes all the way over here. It actually also looks like dandruff because it's got a little dandruff, and it's hard to tell sometimes where the end of the dandruff area is and where the beginning of the skin cancer is. But if you squeeze it hard, and you can see there's little blood vessels going in. So this is the nodular, and right off to the side there is the morphiiform. It's infiltrated. Now, how do you treat it? You can treat it with a cream. If it's superficial, you can treat it with a pill called Eriveg. And I've developed techniques where I can cure it, not only treat it with it, because if you just use the pill, it will come back once you stop the pill after a month or two. There are other pills similar to that, like Vismodegib, there's Odamzo, the same kind of idea like Eriveg. There are now IV therapies that can be done, but all those that are helping to program the death of the cells, they do not cure the basal. So the most effective, the gold standard, the one that gives the highest cure rate, is the Mohs surgery, named after the person who in the 1950s invented the procedure of examining the skin cancer, the tissue that you removed under the microscope, all around and in the base. And this is what we're doing today, especially when you do it on the face. You want to make sure that there is less likelihood of recurrence. Now, nothing in the world is 100%, because there's humans involved in it. We try to reduce the amount of variables to make sure that we get everything and we see the entire edge. If we don't, I will discuss with the patient and I'll make sure that I do the best that I can. I have the best technician, everything we do to make sure that we see the edge. Because if we don't pay attention to the edge, if we don't have the edge everywhere, it could be that exact one little millimeter of a spot, a micrometer, that has the basal, and the basal skin cancer will come back. So it's important to remove it early. If you do, you have a smaller scar, and that's what Mohs surgery actually does. Other skin cancers, less common, are squamous cell carcinomas. If you have vitiligo, you don't have pigment cells, it's more common to have squamous cell actually than basal, because they're more connected with UV light. Basal have other things that can cause it. It's important that you have proper supplementation, coenzyme Q10, NMN, which originates from vitamin B3, which with time, with age, the efficacy of the body to break that into the effective NAD molecule is reduced. So it's important that you supplement either with nicotinic acid, nicotinamide, NR, NMN, or IV NAD, any of them. And vitamin C, etc. Vitamin D, and sun protection. Also, you want to avoid some of the carcinogens. Carcinogens are things that are increasing the risk of mutations in your body. They include the sun, the UV radiation. They include some foods, especially charred foods. So if you like that grilled looking meat and it has that black lines in it, it's not very healthy. Red meats, there is a discussion back and forth, but overall it's probably safer to not have too much of that red meat. And arsenic. So you can see sometimes people, they have drank from wells and they didn't check the quality of the water. They have little pits in their hands from arsenic. they are also an increased risk of developing basal cell. What I have personally seen, and it's my theory, I believe it is true, is that it's also related to exposure to radioactive particles as uranium. And I've seen a lot of people post Chernobyl, which occurred in 1986, right, in Ukraine, in Chernobyl, that developed it only on their scalp. In Moscow, for example, when they made them go out on the usual parade that they forced everybody, even though it was far removed from the epicenter of the reactor, there was rain, and the rain and the wind brought it with them, and the rain caused it to settle down. And I have people who practically 99% of their basals, gazillion of them, on their scalp occurred later. So I believe there is still a little small particles of uranium stuck in the skin that cause chronic inflammation, and we know that chronic inflammation can also lead to skin cancer, more commonly squamous cell, but can also lead to basal cells. For example, margarine ulcer, which is a long-standing ulcer, after 20 years down the line can lead to squamous cell carcinoma. All of this is due to inflammation. So not to worry, I gave you a lot of information, maybe too much information, but the key is, if you try to avoid the carcinogen, most importantly, sun protection. Physical blocker better than chemical blocker, but any sun protection is better than no sun protection. Hats, avoiding the sun in the middle of the day, supplementing with proper supplementation, and seeing a doctor on a regular basis. And if the doctor doesn't want to do a biopsy because he's worried that he's going to leave a mark, maybe you should be vigilant and tell them, you know what, I really would rather you do a biopsy, because we all make mistakes. I make mistakes myself as well. So it's important that you will help the physician by making sure that they know that you are interested in your health by going ahead and actively participating in the care of your skin. So right now what you can see is this was already biopsy. It was a basal skin cancer, and she did notice another lesion over here. And this lesion over here, if I squeeze it, it has a little bump around it. This could be also a basal skin cancer, although it could be a precancer as well. So we're going to remove this with a microscope called Mohs surgery, and we'll show it to you afterwards under the microscope. And this will just take for a biopsy to make sure we don't miss anything else. We'll be able to show you how it looked before, but it basically looked like a little nothing. But the point is that if it doesn't go away, as I said, a month or 2 months, you better take it and test it, make sure it's not a skin cancer. So what we're doing here is we're preparing the slides so that we can examine it under the microscope. And Javier is cutting the tissue in very, very thin layers, as you can see here. This is the cryostat machine where it's being cut. And you can see the thin layers being prepared and then applied on top of the slide. Once it's applied on top of the slide, it's stained right over here in a special stainer. And then we're using it under the microscope to examine it. This is the tissue that we removed from the cheek to examine, and everywhere it was clear except this area over here. Over here what you can see is this is the basaloid cells, this is the skin cancer. It's not at the depth, it's not right at the edge, it's in the dermal area. So now that we know where it is, what we're doing is we're going into the area and we're drawing it. So this basically, the entire area here was clear and only that region over there was positive. And if you look further down, it's the epidermis, the dermis, the fat, and this is not everywhere. And that corresponds, this is different hashes and different colors that we stain it with. Everything else, everywhere else was clear. So this is basically what you saw, that thin tissue, after it's being placed on the microscope and stained. That's how it looks with the colors. Let me give you a little bit more color so you can see it better. And this is if you look at it in closer up. And you can see here also some hair follicles. This is a normal hair follicle. Almost looks like a basal, but it's not. So basically what we need to do is we need to go back to that area. So we're not going to remove everywhere. We have little markers to identify where we were, and we're just going to remove the area that was abnormal. So we have to go a little bit of depth, not all the way down, a little bit of the epidermis and dermis, so a little bit here. And this was the hash, so we're going to go a little bit beyond the hash. And this way we can reduce the amount of healthy tissue removed and only remove the area where the skin cancer was. So we'll take another stage, and then we'll see, hopefully that will be negative. So now that we've examined the tissue under the microscope, we know exactly what area is left. There's a very little small area left, not in the depth, just a little wider, and it's about 20% of the area. So we're just going to go a little closer towards the nose, take a little small sliver and do it again under the biopsy. About 30 minutes, we should get the result, and depending on the answer, hopefully it's negative, we can put stitches, okay?
Mhm.